The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. I'm going to start out first with a sound check. So if you can hear me, if you would raise your hand using the hand icon, then I'll know that we're connected. Great, I see some hands. So we're good. We have a lot of people scheduled to attend today, and we only have a fraction of those online right now. So I'm going to give it another couple minutes and then we'll get started. Okay. Good afternoon. Welcome to the Colorado Medical Board Stakeholder Meeting to discuss voluntary confidential treatment and monitoring through the board's designated peer assistance provider. I'm Karen McGovern, the Deputy Division Director of Legal Affairs for the Division of Professions and Occupations, which is the umbrella agency that houses the Colorado Medical Board. Joining me today is Paula Martinez, who is the Program Director for the Medical Board. I also believe that we have Dr. Donald Lefkowitz on the line, who is the current president of the Colorado Medical Board. I want to thank you all for taking the time to attend this meeting. It's very important that we hear from you on this really important topic. Today, to get us started, I'm going to start out with explaining how to engage on this virtual platform so people know how to provide their comments and making sure that everybody has the opportunity to provide their input. I'm also going to talk about opportunities for future engagement as we work through this early engagement process, but also as the board works through its policy. I'm going to talk a little bit about the voluntary confidential treatment and monitoring, what the current state is. I'm going to talk a little bit about what the board is going to work to do, so why we're here today. And then we're going to do the targeted feedback session, which is going to allow you to provide feedback that's going to help the board as they look to develop a policy on this issue. And then finally, when we get done, we'll talk about the next steps moving forward. So, how-tos for early engagement. So today, through this webinar process, when we get to the stakeholder feedback portion, I will ask people to provide comments. To do that, you'll raise your hand using the hand icon on your screen. When we see your hand raised, we will unmute your line and call on you, and then you'll be able to provide your comments orally. Some people don't feel comfortable in that forum, and I want to make sure that everybody has an opportunity to provide their comments. So if you don't feel comfortable speaking out, or if you can't, or you're having technical difficulties, or if you can't use the audio on your computer, which we see from time to time, you can enter your comments into the written comments and questions box, and then I will read them aloud for the group because I want to make sure those comments make it on the record. And when I talk about the record, I'm saying that this stakeholder meeting is recorded. And what we do is we take all of these comments from this virtual meeting and the one that we had last week on Friday, and then we provide the recording to the board members, and particularly the members of the policy subcommittee, so that they can hear all of your comments, so they can actually listen as if they were at this meeting, and they can listen to what you have to say. And that's why it's really important to make sure that we stay engaged today, we talk about things, making sure that the board has all the information that you want them to have before they start drafting the policy, right? Another way that you can provide feedback is you can put it in writing. You can write a letter, you can send an email, and you can submit that to Paula Martinez at state.co.us. And if you can get that in by today at 5, and I know that that's kind of a rush, or even tomorrow morning, then we can make sure and get all of those written comments together so that we can get those to the board when they, or the board subcommittee when they meet on the 11th. So they'll have all of that information. We also sent out a survey, and we sent the survey out to every licensee, all of the board stakeholders, to make sure that we were providing enough opportunities for people to engage. So if you look at the research involving, public engagement, you'll see that people like to engage in different ways. The survey allows people to engage anonymously, and that's how some people feel most comfortable providing their comments. Some people don't like to be in this open forum and to speak out or to have their name associated with things. And it's important that every stakeholder have the opportunity to provide their comments, their opinions, their feedback about this topic. We're talking about confidential treatment, voluntary confidential treatment for medical board licensees. And right now we have roughly 30,000 licensees. And so if you think about it, we had roughly 85 people on the last meeting. We have about 85 people scheduled for this meeting. That's just a very small fraction. So we wanted to provide other mediums for people to engage so that we can get the most feedback possible. And actually, and I'm going to go back because I also want to address something up front. And the reason I want to kind of change the order in this meeting was I intended in the last meeting to address it last, but I got a lot of questions during the webinar. This is early engagement. What early engagement means is we want to know what you think before the pen goes to the paper by the policy subcommittee, right? So getting your thoughts out now gives them a place to start. Once they draft a policy and it is approved by the full board, and the full board meets later in February, the 18th, I believe. Once we have a proposed policy, we will come back to you. You will have an opportunity to look at the written policy and re-engage. So this isn't the only time that we're going to ask you what you think. We're just asking what your thoughts are now prior to starting the policy, so that that policy can mirror, what people are looking for, so that then when you get the policy to review, it should more closely reflect your thoughts and opinions. Okay, so confidential treatment, what is the current state? So I think it's really important for people to understand that the Colorado Medical Board has long recognized the importance of licensee privacy, early intervention for licensee health conditions, and its positive impact on patient safety. That has been the position of the medical board for years, right? Really since the creation of the Peer Assistance Provider Fund. And the board is not looking to upend that or not have that. So the current state of this confidential treatment is premised on the licensee or the applicant for the medical board seeking help from a peer assistance provider before the condition impacts practice or results in legal issues. And that's really been the premise of the current state. The confidentiality from the board has really been contingent upon compliance with the recommendations of the peer assistance provider. And even though the board has had sort of this undefined policy or this support for the confidential treatment, there's never been a written board policy that clarifies or defines these parameters. If you look over here on the right side of the screen as you're looking at it, there was a survey done in 2018, and it talked about monitoring physician health for the 70 state medical boards. And what's really notable is only 14 medical boards out of 70 require board notification of all peer assistance provider participants. And Colorado is not one of those states, and it has not been. So it's very clearly a minority of medical boards. But 65 of the 70 medical boards require board notification for participants in these confidential programs who fail to adhere to the peer assistant provider requirements. So I wanted to add this on here just as sort of a national view, so we kind of understand the current state. Now, while I said we haven't memorialized the parameters of the confidential program in a policy, it is important to understand that the current contract for the peer assistance provider says that all mental or physical illnesses or conditions qualify for confidential treatment and monitoring with the following exclusions. So if you're a voluntary recipient who refers for an illness or condition that has already resulted in substandard medical practice or patient harm, you are not eligible for this confidential treatment monitoring program. Or if you're a voluntary recipient who refers for an illness or condition that has resulted in or contributed to a violation of state or federal criminal law, you're not eligible for the confidential treatment program. It's important to know that municipal offenses and minor traffic violations that do not involve drugs or alcohol would not make that person ineligible. And then finally, the last exclusion is a voluntary recipient who self-refers for an illness or condition that has already resulted in or contributed to an adverse action or a professional disciplinary action, right? So those people would not be eligible. That is the current state of the voluntary confidential treatment program, if you will. And so if that's our current state, if that's where we're sitting today, then the question is, why are we here, right? So the board is looking to memorialize through board policy the parameters of this program. And then revisiting that, to make sure that they get all of this memorialized in a policy that's transparent and open so that licensees, consumers, everyone can see what this program looks like, we're gathering feedback. We want to gather the feedback because we want to know what you think. And as many of you know, I can see some of the people on the webinar, we frequently hold stakeholder meetings for rulemaking, but the medical board has long held the position that even though the law doesn't require stakeholder engagement or gathering stakeholder feedback for a policy, when these big policies hit, the medical board has long gone to its stakeholders to say, hey, tell us what you think. Tell us what you think about, the medical marijuana policy. Tell us what you think about telehealth. Tell us what you think about, the opioid guidelines. And this, as I talked about, this is very important because this affects roughly 30,000 licensees and all of the patients that they will treat. And so it's really important that we hear from you, and that's why we're here today. So when we start the feedback session, obviously anyone who wants to provide any feedback is welcome to, any feedback that you have regarding this topic. But I think I wanted to provide some targeted questions because sometimes that is a thought provoker, or it helps people articulate what they want to say, or it helps them see sort of the things the board might be looking at so that they can provide that feedback before the policy is written. So I split it up into sort of 5 categories. Eligibility requirements. And so the question is, who is eligible? Who should be eligible? Should the applicant or licensee be required to seek the treatment voluntarily, or does that matter? Can they be mandated there from their employer? Should the request for confidential treatment and monitoring be made prior to an impact on practice? And what is an impact on practice? Is it showing up late for work, or is it patient harm? What do you guys think about those things? Exclusions. Should there be exclusions? And if so, what should they be? And we talked about the ones that are in the current state. Do you agree with those, or do you not agree with those and you think they should change? Like, that's something that might be helpful here. Compliance. Should compliance with peer assistant provider recommendations be required to stay confidential from the board? And if you think so, how do you define compliance? What is that? Or on the flip side, what is non-compliance? Is that easier to define? Limitations. So the question is, at what point, if any, because again, this is up to you, should the peer assistance provider report non-compliance to the board? And I'll tell you, we have some stakeholders that say no, non-compliance should not be reported. Some people say yes. If you say yes, at what point should that happen? And should the applicant or the licensee be advised of any limits to confidentiality before entering the confidential program? Some people say, should they know the rules before they sign up for the game? If that's the case, how should they be notified? And then, the last question is, how do your thoughts ensure patient safety? So if you think there should be eligibility requirements, how does that tie into patient safety? Or if you think there should not be exclusions, how does that tie into patient safety? So again, these are just what I call thought provokers, conversation starters. It's your time. You provide the feedback that you think is important. And so I'm going to quit talking and we are going to get started. So anyone that wants to talk, wants to provide comments, feedback, opinions, raise your hand and we will go down the list and call on you, or type your comments into the question box. And Paula, will you help me by calling out and unmuting lines?
Yes, I have chat C-word. I'm unmuting your line. You're self-muted.
Chat, you're self-muted, but you're open on our end.
Thanks, Paul. Sorry about that. Didn't mean to raise my hand.
No problem.
Okay, I'm checking. Oh, your hand's still up. There you go.
So while Paula's looking, I'm going to go ahead and
I have Neil O'Connor. You're unmuted.
Yeah, that also was an error. Sorry.
Hello? So it looks like we have Sam Shalansky. Your line is unmuted.
Hi, thank you. I actually did intend to raise my hand.
Great.
You know, I'm speaking from the perspective of a physician, and I'll come right out and say I have self-reported to CPHP and am currently involved with them. I like the idea of voluntary reporting being a condition for confidentiality. You know, there was a recent article in the New York Times on January 21st of this year where they actually looked at a study of, I believe it was 827 emergency room physicians, and we're talking about increased burnout. The relevant part is that 45% of those physicians said that they would not seek care because of the stigma associated with mental health issues and how it might affect them. And so I think that there does need to be a bit of a carrot and stick approach to things in order to help ensure patient safety and physician safety. I mean, there were over 400 physicians in the United States last year who committed suicide. And those are the most recent numbers. And the expectation is that with the mental health strain of the pandemic, that those numbers are going to go up. So I really do think that there are a lot of physicians who would benefit from care, but are reluctant to do so because of potential stigma. And so if they are induced to self-report on the condition that they then have confidentiality, I think that that is beneficial. I do think that there should be exclusions. I think that if there are physicians whose illness or behavior has led to significantly adverse outcomes with patients or to legal complications, then I think there are going to be those situations which should be handled directly by the board rather than by a PHP. And I'm a huge fan for compliance being required for maintenance of confidentiality. What constitutes non-compliance is a little bit tricky. Hypothetical situation, if you have someone who is under drug and alcohol monitoring who misses a random drug screen, should one random drug screen result in their losing confidentiality? I don't believe so. If they have a pattern, if they have 3, for example, within a year, that might be considered a pattern of non-compliance that would result in loss of confidentiality. But I really do believe that compliance needs to be a condition of ongoing confidentiality. Thank you very much.
Thank you. We really appreciate that. Looks like we have Karen Sergey. I've unmuted your line. It looks like you're self-muted. There you go.
Yes, good afternoon. Thank you for allowing me to participate in this stakeholder meeting. Before I respond to these targeted feedback, let me give you a quick idea of what I have done during my career. I have been chief of staff of a tertiary care facility, chairman of medical staff leadership for an entire health system, and president of a group of 35 physicians covering Colorado and receiving cases from 26 states. So the reason I'm mentioning that is to really emphasize that the peer program is a lifesaver, not only for the physician involved with treatment, but also for medical staff leaders who are dealing with matters of patient safety, fairness to physicians, fairness to the patient, fairness to the medical staff, to the institution, to their group. And before this came to the surface, I started hearing about it in 2020 during a year of pandemic. I didn't even know that this was in question. And the fact that it was raised during a year of pandemic when physicians may need it the most and their patients may need it the most, the fact that their physicians have an outlet to self-refer in a confidential way created an unbelievable amount of distress, which I would add was unnecessary in a situation where everybody is already stressed and challenged by a worldwide pandemic. Having said that, I'm coming out of ignorance with a question, which is more of a rhetorical question. We never thought it was broken. So I am one of those physicians who are listening to this presentation today and is wondering what happened. I mean, it was working great. It's not broken. I understand the need to codify it, to make it more official, but I would implore you to not change anything to the current policy. Maybe fine-tuning is involved, as the previous caller said, in terms of defining what non-compliance is. Those can be resolved, but touching the core of this policy and the spirit of this policy would be absolutely detrimental to our medical staffs around the state. And I will finish with that and listen with interest and re-intervene if needed. Thank you.
Thank you. I really appreciate your time and I appreciate your thoughtful feedback. It looks like, go ahead, Paula.
Dr. Margaret Reedy,
Okay.
you're unmuted.
Thank you. Can you hear me?
Yes.
Hi, this is Dr. Margaret Reedy from UC Health. And I wanted to thank you very much for engaging stakeholders in this conversation, which we think is very, very important for both patient safety and provider wellness. Colorado is a national leader in physician wellness, and many other states have emulated the approach that the legislators and the medical board have established for several decades here in the state. And I do want to reiterate what the other speakers have called out, that it is a year of global pandemic and our colleagues are suffering unprecedented levels of stress and burnout. A high-performing physician-directed wellness program from which providers are not hesitant to seek care because of concern their treatment won't be discreet has really never been more important than it is today. I will say that the last speaker talked about a good program like this being a lifesaver, both for the physician and physician leaders helping the physician. But I think it's important for us all to note that it's also very important to patient safety. Provider health and wellness impacts patient satisfaction, quality of care, the rate of medical errors, and malpractice risk. And I think that keeping confidential the fact that a provider sought care significantly improves the likelihood that that physician will seek help from a physician assistance program for potential health or behavior challenges. Without that confidentiality, we know that providers rely upon self-diagnosis and treatment, and they achieve far less than optimal results. There is a very positive connection between physician wellness and improved patients' preventive health practice. Further, the American Foundation for Suicide Prevention has long believed that transforming professional attitudes and changing institutional policies to encourage physicians to seek help not only helps those physicians, but also results in physicians being more likely to diagnose and treat depression and mood disorders in their own patients. So we want to emphasize that patient safety and physician health will both benefit if we can strike the right balance between confidentiality and disclosure in this case being considered. to refer directly to your thought provokers, I do think that physicians who present either mandatorily or voluntarily should be considered for eligibility for confidential treatment and management of the condition, largely because they are impaired. People can be impaired based on substance use disorders, severe psychiatric disorders, including depression. And I think that the same impairments that are threatening your ability to practice medicine can also impact those providers' judgments. And I think those of us who are in physician leadership have seen lots of cases where doctors have benefited from engagement with a peer assistance program where a month in they say, I had no idea how bad I was until I got here. I think certainly there should be some exclusions. And I think the ones outlined are certainly a starting place for discussion. I don't think that compliance should be an exclusion because I think it should somewhat depend upon what the circumstance is. It would seem fair to me that compliance should be defined based on the specific provider's circumstance on a case-by-case basis, and that provider who is engaged with the peer assistance program should understand what compliance failures would result in a loss of their confidential treatment status. And I do certainly think that applicants to the program should be advised of the limits of any confidentiality based on both compliance and any other considerations. I would strongly encourage you to take this feedback and think about the impacts, not just on the providers involved, but on the patients they serve. It's very difficult to say at what point a physician's practice is impacted, and any detriment or barrier to physicians reporting themselves makes it more likely that their practice is impacted. Thank you very much for your consideration and your time today.
Thank you. I really appreciate your feedback, and I appreciate you going through some of these kind of discussion starters. It's really helpful. Looks like we have Sammy Diab, and let me start by saying I apologize if I mispronounce anyone's name. Sammy, you're unmuted.
Yes, thank you for the opportunity, and you did a great job pronouncing my name correctly.
Great.
So Sammy Diab, president of Colorado Medical Society. First of all, thank you so much for the stakeholders meeting and for the opportunity to express our opinions as providers and organization. It's certainly enhanced the trust between DORA and physicians during this very challenging time for physicians. I totally agree with all the previous comments about the need to protect the physician's confidentiality in order to have a healthy physician communities that's able to do its job right. A healthier physician means healthier communities as well. So my main point I would like to make is, in the absence of data, which yet I'm to hear, the existing system, regardless of who has the contract, is working very, very well. And after the first listening session, I went back and tried to find what's the existing confidentiality statement by the current deliverer of the physician counseling, Colorado Physician Health Program, essentially. So I went and looked at their consent form that you have to sign. And I really would encourage the medical board to look at that consent and take exactly the same language, regardless of who is the provider, and apply that, because that system is already working very well. And I haven't heard any data. I would like to see if there's any data to indicate that there's any harm being done by following those guidelines. So in the consent form, we have 4 statements on when the Colorado Physician Health Program or whoever is the provider of the service can break confidentiality. And I think those are very reasonable and working very well. So the first one is if there's a determination that by that entity, right now is CPHP, if there's a danger to yourself or other, or you might represent a significant risk in your medical practice. The second one, if you have failed to comply, and that's the answer to your compliance point, but in addition to failure to comply, that failure to comply is associated with a danger to yourself or others in your medical practice. So it's not just a lack of compliance, unless that lack of compliance is leading to potential danger to the self or to the practice, meaning to the patients. Or a determination by the staff that an obligation to report exists based on violation or one or more provision of the Colorado Medical Practice Act in which harm to patient may have occurred. And the last one is a subpoena issued by Colorado Medical Board. I truly believe that those 4 exclusions have served the community very well, and encourage the Colorado Medical Board to stick with those when they're writing the policy. Thank you so much.
Thank you. I really appreciate your feedback. Paula, who's next?
We have Bruce Ward.
Okay.
You're unmuted. Wait, hold on.
Yeah, can you hear me now? Sorry.
Yes. We got you.
I want to emphasize I am just a regular Joe. I'm an ER physician for 30 years in Colorado, and I'd like to thank the people who spoke before me because I think their thoughts were well organized and very accurate. The main thing I would like to say after watching physician health plummet in our state, and especially my specialty for the last probably 10 or 15 years, is that the threshold needs to be as low as possible for these programs, and that the security of confidentiality needs to be as secure as possible. I've served for many years on our citizenship committee where we have referred tons of people to CPHP, and it's been very useful and helpful for many. And honestly, most of the people have had some sort of negative impact on their practice as their first indication that there was a problem. So personally, I believe that that needs to be removed if that's one of the issues that removes confidentiality, is have there been impact on the practice. Of course there's going to be impact on a practice if there's a problem. So that seems silly to take that away. Patient harm is a different issue, and that's not what I mean by that. We need to keep confidentiality at all costs. Frequently what we're dealing with in these referrals is addiction, substance use, substance abuse issues, and it's well documented that relapse is a part of that illness. And to have relapse be defined as non-compliance, therefore sacrificing confidentiality is that needs to be addressed clearly in whatever new language is set up for this. And the primary thing that I want to say has really impacted me as an ER physician is people are so afraid to address problems because they think it's going to have a negative impact on their practice, when in fact what it's going to really do is have a positive impact on their practice. And every person that I've been involved with who's been referred or who has voluntarily referred themselves has always come back and been very thankful about the process, but the concern about confidentiality has kept so many other people away from that devastating consequence. So we need to keep an eye towards confidentiality. There is many guardrails in place for patient safety, and I do believe patient safety does need to be the most important guiding light, but without losing focus on the confidentiality, because that is what's keeping people from referring and getting well. And it's pretty sad, the state of emergency medicine for sure, but medicine in general, and how mentally ill we are at this point. Thanks.
Thank you. And I had a kind of a follow-up question if you want to stay on for a second. I was wondering, do you think then that memorializing this in a policy, right, so a written policy that everyone can see, do you think that will help physicians feel more comfortable seeking treatment? Or what other interventions would help?
Absolutely. I can't say how many times when we'd be in a meeting agonizing about a person who was having difficulties on medical staff and who was acting out because of that, where we would try to go through the policy that as it existed step by step to try to figure out whether this was going to be a reportable incident or not. And the more clearly it's set up, the better that is for staff organizations, but also for individual physicians, something that they can go to on their own in their time of need, quietly and confidentially on their own, and review these things and feel reassured and feel encouraged, and then to self-report. It's a really, really valuable tool.
Okay, thank you. And do you think if once we get that policy in place, if we, if Dora or on behalf of the medical board did some more outreach and maybe did, I don't know, YouTube videos or something to outreach around the state, then people would understand it's available to them? Do you think maybe, is that an issue? Maybe they just don't know what's available?
No, I think most people know it's available, but very frequently it's utilized as a sort of stopgap measure by a hospital staff committee. And so they realize what's inherent in that process is that this is your last chance kind of thing, or this is your warning kind of thing. And so they don't want to be associated with that. And I think what might be very helpful for people not on, staff committees, but individual physicians who can benefit from these programs is ongoing outreach, periodic outreach, where this is brought up and advertised, advocate for it, and encouraging people to seek this out. Because as it stands now, it's really not like that. And there's been plenty of times where I'm aware of hospital staff maybe not observing as much confidentiality as needs to be maintained in these situations, or hoping to breach that confidentiality so they can find something out to get this, to get a problematic person off a committee or off a staff. And that's probably not the intention of the program.
No. Okay. Well, thank you. Thanks for letting me put you on the spot.
Yeah, no problem. Thank you very much for your time today, guys.
Yep. Who's next, Paula?
James Meyer.
Okay.
Hi,
Yeah.
thanks for doing this. So I'm a little confused about why we're talking about confidentiality, and I can only give you my experience. I have actually been involved in the CPHP program starting up to 10 years ago. And I think that the people I've worked with would be willing to let you know that I'm clearly a success story in terms of how my practice is thriving and my life is much improved based on that. What I'm a little confused about is it seems as though it's all started when it decided to give the contract to somebody else besides CPHP. And I would thoroughly agree that if it ain't broke, don't fix it. I too have sat on credentialing committees for over 10 years. And have been involved in medical staff. And so I do have some experience with how people are sent to CPHP in the first place. The second thing I'd just like to say, which maybe is a lack of my ability to understand the survey, but the survey that was sent out from DORA was extremely complicated. And if you only have a small percentage of the 30,000 licensed physicians doing this and another 2,000 filling out a survey, that survey was very confusing in terms of what it was trying to achieve. I felt like I was able to answer it to the best of my ability, and I do hope that everybody else will. Now, having said that, the confusion is sort of like, well, here we are, now we're talking about confidentiality.
again, I can only speak to my experience. I was brought to CPHP based on the fact that I was brought to the medical board and I was told I needed to participate in CPHP. And as far as compliance goes, I think that we should leave it to the experts. CPHP has very well-defined non-compliance and compliance issues, when to report to the board. And I can tell you beyond a shadow of a doubt that when I was being treated by CPHP, and I was compliant, thank you. However, I had the utmost compliance, I had the utmost confidence that not so much that if I messed up that I would be turned in, but more importantly, as I was going through treatment, that I did not have to worry about having eyes in the back of my head in terms of the medical board saying, oh, by the way, you need to do this or other things. The one thing I have a concern about is making now, if it comes from the medical board, it's already come to the medical board. So I don't know that that means that there's a lack of confidentiality or not, but I think once a person's in a program, we should let CPHP do their job. And they've done an excellent job as far as I'm concerned. The one gentleman also said that when you're sitting on a credentialing committee and you have a letter from CPHP and somebody who's been participating in that, and it comes to renewing their credentials, it's basically a rubber stamp. That's the type of care that CPHP is providing to Colorado physicians for a long time. And I've talked to other physicians in other states, and CPHP is sort of the model at this point. And so I'm extremely grateful that we have CPHP in the state of Colorado and that we can have that confidence. And more importantly, that all the staff members that sit at hospitals can literally have the confidence and say that if they see a letter from CPHP, this doctor can continue to practice medicine. The only other thing I'll say is that it is a huge slippery slope. When you sit in medical staff meetings and you have a doctor who is not necessarily, you wonder if they're impaired or not, it almost always comes from patient care. Now, there are some people that will use that to get doctors off staff. That's a separate issue. It becomes political. But in the problem is that if you say that you have to report this to the medical board if somebody goes to CPHP because there's been impact on practice or impact on patients, that had to happen in the first place. And I think that a lot of the meetings that I'm in, that they tend to be a little bit scared. It's like, well, if we don't say anything, we could be held accountable or something. And then it becomes not so much about the physician, but protecting the practice in the hospital. And I think that's where it gets to be a slippery slope in terms of trying to make this into a firm medical policy. The other thing I think that hasn't been discussed is that the minute that this goes to the medical board, and that if the medical board decides to say, oh, well, we really want to help this person, so we're going to stip their license and give them a restricted license until they are cleared by CPHP, then the downstream of that is huge. There are medical boards that will basically take away your medical boards if you have a stipulated license. Number one. Now, and I've seen doctors that's happened to. The second thing is that the minute you have a stipulated license, because the medical board gets somebody and says, well, this is pretty serious, we better stip this guy because we all want to protect everybody, right? The other thing is the second thing as far as losing your medical boards is that you can be taken off insurance contracts. There are many insurance contracts that will say that if you have a restricted license, and sometimes they have categories in terms of whether or not this is a health or an alcohol or drug issue, but not that many do. And so they're going to lose insurance things. So I think there's more to this than just whether or not doctors have confidentiality, which I think is really important. I'm not even sure, I agree. I'm not even sure why this is becoming an issue right now during a pandemic. So I really appreciate allowing me to give my comments, and thank you so much for doing this. That's all I will say for now. Thank you.
Thank you. And I think maybe I wasn't clear, and so maybe I can clear that up a little bit. I don't think it's not becoming an issue saying that the board doesn't want people to have confidentiality. The board wants to memorialize the confidential treatment program into a policy so that it is transparent and people understand what that means to them and also so that regardless of who a peer assistance provider may be, they're bound by what the board sets out. And since the board was going to memorialize it in writing, they want to take the opportunity to hear what people think about the current state and if it should change, or what things they could add to make it more clear, or what things do people think should be taken out of the current state. And I put that slide back up here just to make sure, basically it's the board checking in with you before they take pen to paper. And so I want to make sure in the event I wasn't very clear, and that's always possible. So I wanted to kind of clear that up, and I hope that's helpful. Paula, if you can look for the next person, I'm going to go ahead and look at our chat box and read out some of those comments while you figure out who's next, okay?
So I do have Chet Seaward next.
Okay. So it looks like there were a couple of just housekeeping matters, like I'm able to hear you. Can you please leave this slide? Someone did ask, are there some slides for earlier for additional prompts from Justin Howell? I did tell him I would go back to this exclusion page. A question from Jonathan Ritvo. What advisements of limits of confidentiality or self-referrals given presently? I would like to add that when it appeared that PAS would be replacing CPHP with resulting loss in confidentiality, I decided that I would rather leave the state and practice somewhere confidentiality could be maintained. That is Sam Shalansky. Justin Howell said, excellent comments from the contribution just now. I wholeheartedly agree. Justin Howell said, I agree that compliance should be defined case by case. Dr. Sirgi says, I don't think all physicians in Colorado know that it is available. It's a knowledge known by physicians in leadership positions usually, and that was also from Dr. Sirgi. Justin Howell, I'm sorry, and I apologize if I'm saying your last name wrong. Are there any provisions in current policy around physicians who seek care on their own outside of the peer assistant provider, and whether or not the treating provider must make a recommendation that the physician under treatment subsequently be referred to the PAP if the treating provider thinks there's a cause for concern? If so, do they relinquish their role as the care provider if they make this recommendation? And then Dr. Sirgi says, I'm referring to confidentiality in the message above when he said he didn't think physicians knew about that. So those are our comments so far. Paula, go ahead and unmute the next person.
Okay, Chet, you are unmuted.
Thank you, Paula. The issue I was going to raise was surfaced by other speakers, so rather than repeating, I'll let it go. Thanks.
Okay, next we have Rachel Davis.
Okay.
Hi, this is Rachel Davis. Can you hear me?
Yes.
Yes.
All right, so I am interim vice chair for clinical affairs at the Department of Psychiatry at CU Anschutz, and I'm also medical director. And I've been there about 8 years now, and over the past 8 years, I've referred many medical students and also a number of residents, and I also treat quite a few physicians as well. And especially for medical students, they're not licensed. The confidentiality is very important because they otherwise have no motivation or requirement to self-refer to CPHP. And I've thus far been able to present it as an option for really extra support and something that will help them hold themselves accountability. And in the absence of confidentiality, I don't see why or how I could convince a medical student to self-refer. And so I echo what others have said about what we are currently doing with CPHP works well. And I appreciated whoever pointed out that the 4 statements in their confidentiality agreement specifically work well. And so I appreciate this opportunity to put into statute these aspects of confidentiality so that they're not at risk if if the contract happened to go to a different vendor. I would also say that with the physicians I treat, over the last year, I've been more reluctant to encourage people to self-refer, not knowing what might happen to confidentiality and to the contract. And so my threshold for encouraging self-referral has been higher, unfortunately. And that's especially unfortunate during this time with the pandemic and with the degree of suffering that physicians are facing right now. With the future of CPHP and confidentiality up in the air, that has made it less of a feasible option. And then I will also say I have self-referred myself to CPHP, and I referred myself as a medical student. I have OCD, and my practice hadn't been impaired, and it hasn't been. But given that there was a confidential option, there didn't seem to be any harm in self-referring, and to have another layer of support and to hold myself accountable and to ensure that I was able to continue to practice safely. And wouldn't have occurred to me to self-refer if I knew that was going to be reported to the board, because I wasn't a risk to my patients and I wasn't impaired. So I think that basically summarizes the points I wanted to make.
Thank you. I really appreciate that, and I appreciate you sharing, because that's really good information and really good for the board to know about. So I appreciate it. I'm going to go ahead and unmute Lynn Perry. You're unmuted on my end. It looks like you're muted on yours. There you go.
Not anymore. Thank you. I want to express my appreciation of everybody who is hosting this call and also who is listening and giving up the opportunity to be glued to whatever streaming services are showing the current activity in Washington. That being said, I'm going to repeat what everybody has said, mostly because, as you know, we as physicians have to be told something 17 times in research before we actually adopt it into practice. So I want to concentrate on just a couple of areas. One is the survey. Last time you did say we could not answer questions, but as it turns out, if you don't answer all the questions, you can't submit it. And the problem that I had is if you ask the wrong questions, you actually can't answer the questions. So most of them were like, if a physician is bad, they should be reported. They were so vague that there was no way you could agree or disagree with them. And I think you need to take that into account when you look at the information that you receive for the people who did submit that. I think the problem is, and the impression that I got from the survey as well is, I'm very concerned that as you memorialize a very important part of confidentiality, that you don't try to micromanage it. What you've heard today from people is essential, that things like compliance have to be done on a case-by-case basis by the peer assistance program that is seeing that person. You cannot put a list of rules in it and then expect that to be effective. It will be more harmful than good. I think that all of the decisions are really made, and Dr. Diab read them out one by one, is if that those decisions, whether it's exemptions, the level at which somebody is reported, what the level of compliance is if that person is at risk to themselves or to patients, period. And that can only be determined by the people who are seeing that person. If you definition beyond what it currently is, then I think you will erode trust both with the public and with the physicians who are being seen. So I know this has been said. I just wanted to say it again. Thank you very much.
Thank you, Dr. Perry. It's always a pleasure. And you know, in regards to the survey, I appreciate your feedback. We're always looking at ways to engage and get more people involved, and we'll certainly take your feedback. Neil O'Connor, looks like your hand is up. I have unmuted you on my end.
All right, perfect. And this time it wasn't a mistake.
Okay.
I kind of want to build on what Dr. Diab and Dr. Perry kind of talked about. And as background, I'm Chief Medical Officer for CarePoint, which is a large private multi-specialty group in the Denver metro area. And as CMO, obviously, had to refer folks to CPHP typically with great success. And the measures of good outcome would be, the practitioner gets back to practice in a safe fashion. We know that the patients are safe. The hospital knows that the practitioner is appropriate for clinical care, and we feel safe as a practice, putting that practitioner back out on the floor. And I would say to sort of reiterate what Dr. Perry said, the micromanagement pieces, or getting too detailed in what is reported back to the board, I think would be a huge challenge, because you can't anticipate every outcome, and ultimately you need to trust the judgment of the entity or the peer support provider. And certainly with the current vendor, CPHP, we've had a lot of experience with them. We certainly trust their judgment. And so I would advocate for going with who has a good track record, rather than trying to write rules for every potential reportable event to the board.
Okay. Thank you. Really appreciate that. Paula, who's next?
So I have Taz Caterpran. You're unmuted.
All righty. I actually wrote my questions or feedback in the box just in case we were running out of time. So I'll just briefly say, I'd like to pivot the discussion just a little bit, because a lot of the targeted feedback is all about, the physicians seeking the care and what should be their limitations, et cetera. But one really important point I want to make is who is going to be delivering the care to these physicians. And the key word is peer assistance. And so should we, including myself, ever seek a treatment, I would expect that I'm being treated by someone who is truly a peer, meaning at my level of education, or even more specifically, subspecialized. And so one of the points I just wanted to make is that is also important as far as whichever program you end up choosing. And not only does it ensure patient safety for the patients that physician is treating, but it ensures patient safety for the physician who is now the patient receiving treatment. So thank you.
Thank you. I appreciate your feedback. Who's next, Paula?
We have Scott Berger. You are unmuted.
Thanks for taking the time to do this today. I just wanted to make a couple of quick comments, if I may. I'm a physician. I practice at a medium-sized hospital here in Colorado. I've been involved with the peer review process for a little over a decade and chaired the committee for 3 years. So I had several experiences with CPHP, which were all tremendously positive. And they provide a tool that helps you protect patients and help save physician careers. And I worry greatly that if you start limiting the confidentiality of any of that process, that it's going to be a tremendous disincentive for physicians to participate in corrective actions, whether it's from poor patient care or from being a bad citizen on a medical staff, what have you. And I think somebody was asking earlier, physicians aren't participating in it because they don't realize that it's there. And I can tell you that until I started participating in a peer review committee, I had no idea that CPHP existed, honestly, and that it is a resource out there for physicians. So maybe some greater outreach, whether it's on the part of the board, letting physicians know that this even is there for them would be helpful, because especially in time of a pandemic, as people have said before, I'm sure the need is greatly enhanced over what it has been. Anyway, thank you.
Thank you. I appreciate that. It looks like Mr. Seward, you have your hand up, or Chet Seward, I'm unmuting your line. I've unmuted you. Chet Seward. Okay, it may just have been a remaining hand up. We kind of cancel each other out in these webinars. So who else? Paula, do you see any other hands?
I don't see any other hands.
Okay, let me take a look at our question box and see what comments we have. It looks like, let's see, I'm gonna start at the bottom here. Looks like Taj Kadaparam, she put in her comments, but she also made them verbally. So it looks like we have Margaret Peg Reedy. As substandard medical practice or patient harm can be very subjective, I would favor removing the first exclusion. Similarly, often an adverse or professional disciplinary action can often be the inciting event that prompts a referral to peer assistance program, and therefore would favor removing that as well. And looks like we've got this. Dr. Ritvo said, or Jonathan Ritvo said, Dr. Diab answered the question. And that's all we have in the question box. So I'm looking out, I'm not seeing any hands. Oh, I do see one. It looks like we have Deb Parsons. I'm unmuting your line. Looks like you're self-muted. Deb Parsons.
Great. Hi, thank you so much. This is Dr. Deb Parsons, and I want just to make a couple points, nothing in detail because wonderful commentary has already been delivered. But I do want to emphasize that I wish the board would look closely at the partnership that the Colorado Medical Society had with COPIC and the Colorado Hospital Association, and at the policy recommendations that were put forth and discussed by our current president, Dr. Sammy Diab. Second, I've been a lifelong physician educator in my career, both as associate program director for an internal medicine residency, and now I currently teach medical students. And just one quick example, just within this last school year or last calendar year, have referred a failing medical student to our state's peer assistant program, currently CPHP. But the student voluntarily engaged after and entered the program after assurance that the confidentiality of their client or patient client privilege would be protected. There had been no injury to patients, no substance use disorder, but there was a huge adjustment disorder going on, and CPHP was instrumental in helping this medical student. As Dr. Rachel from the psychiatry department at University Illustrated, I too have referred over my 20, 30-year career numerous residents and medical students who have their entire career in front of them. And it is unlikely most would have walked through that door of the peer assistance program had their medical information not been confidential up front. And it's hard when when an entire career lies ahead of you in terms of how you think you can deal with something. And many people will say, oh, I can deal with this on my own, or I'll talk to friends, I'll talk to family, maybe I'll do professional help, which is expensive. And in most of these cases, the peer assistance programs have been invaluable. I did want to say, looking at some of the examples that have been repetitively put up on the slides that came from the survey, you know, it's true that a lot of those scenarios sometimes look egregious, but I think if you wind back and map out what is it that we're really trying to do, and we're trying to get physicians through the door early. And if you can't get the physician through the door, they're not going to get help. They only get early treatment if they come in, not if they stay away. And so in most all of those cases, there would be many physicians who would not voluntarily and self-refer. I believe that first scenario is an automatic referral to the board, but getting voluntary treatment is still a different cat. And there may be other things going on. That first scenario did have some patient harm and should be reported. And yet a voluntary referral of a doctor to get treatment needs to have confidential protection for all of the other information that we expect when any professional seeks, any professional who is in the public, I'm sorry, I'm trying to read this. When any professional seeks treatment, like other persons whose occupations are critical to public welfare, early diagnosis and successful treatment is in the best interest of the public. And so I'm reiterating, the students and residents are unlikely to get this provided help for them with their high tuitions, their high burden of responsibilities, their underlying, just the underlying stress of the current year. And I highly recommend that we look at what the Colorado Medical Society, COPIC, and Colorado Hospital Association has submitted as recommended policy. Thank you.
Thank you. I really appreciate your comments and the thoughtfulness with which you approached this. It looks like Dr. Lefkowitz wants to make a statement, so I'm going to unmute his line. Dr. Lefkowitz, you're unmuted on my end.
Thank you, Karen. Can you hear me okay?
Yes.
I just want to take a minute to thank our callers and speakers and people who submitted comments in writing. It's extraordinarily helpful to hear from all of you. I recognize, for those of you who don't know me, I'm currently the president of the medical board. I think all of us on the medical board, and I specifically, recognize the extraordinarily stressful time this is for our providers. And I just want you to know that we recognize also that serving our mission of protecting the public cannot be better served than if we protect the health and well-being of our licensees, all 30,000 of them. And your input today has been very helpful, and we will take that back to the full board and use it in that mission to support our licensees out there. So thank you all for participating. And I don't mean to close it out if other people have other comments. I just wanted to make sure I had a chance to say that. Thank you.
Thank you, Dr. Lefkowitz. All right, let's see. It looks like, Chet, it looks like your hand is up again. So I'm going to try again to unmute your line. You're unmuted. Chet Seward? I don't know what's going on. Okay. Let's see. Paula, who else do we have?
We have Dr. Sergi.
Okay.
Thank you. This is Kareem Sergi again. Thank you for the opportunity to add to my previous comment. I'd like to mention an additional aspect of this entire conversation. At some point, somebody said, the previous caller said that most physicians or all physicians know about the program and about the confidentiality aspect of it. And I made a comment in writing that I don't think that many of my colleagues know about the programs, the peer referral program and the confidential nature of it, but I'm going to push it one step further based on true stories and true experiences during my tenure as a medical staff leader. The families of physicians don't know about this program. And we forget that almost always families of providing physicians are directly affected by whatever impairment they may be experiencing. And I had at least 2 situations where the spouse of a referred physician came to me personally as chief of medical staff, and I was really wary of the interaction, thinking that it was going to be along the lines of blaming or whatever, but it turned out to be thank you for pointing my husband, my wife to this program. Things were getting terrible at home. We didn't know that something like that existed, that it was protective and confidential to my spouse, and you basically saved our family life. So not only do physicians need to be informed about this program, but I would advise the board at some point, respectfully advise the board that at some point when you have the policy together and it's finalized, the public needs to know about it, families of physicians need to know about it. It's a lifesaver. And I didn't want to go into specific names and specific companies, but I second everything that has been said about CPHP. They have been nothing short of fantastic in every single interaction we had with them through the years. And thank you again for the opportunity.
Absolutely, thank you. Looks like we have Scott Berger, so I'm going to unmute your line. You're unmuted on my end, but you're self-muted. Okay.
Sorry, that was a mistake on my part.
Okay, no worries. Sometimes we cancel each other out. You lower your hand, I lower your hand. It's all good. We understand sort of the weird world we're in these days. Who else do we have, Paula?
Chet Seward, his hand is still up, so I'm not sure if that's a mistake.
Okay, let's try him again. Chet Seward, I've unmuted your line. We are not hearing you, and so I'm wondering if there's a problem with your audio. Let me see. Okay, he doesn't have any further questions, so there's something wrong either with the program, or it might be just that there's something wrong with me. So I apologize, Mr. Seward. Let me look. Do we have anyone else?
Dr. Lefkowitz's hand's up, but I don't know if it was just continued from the last time.
Maybe you can unmute his line and see, Paula.
Okay. Do I unmute?
I'm good. Thanks anyway.
Okay.
Okay.
Good. All right. I don't see anybody else, but I really want to make sure, because we're all here and we all have the time blocked out. I want to make sure if there's anything else people want to add about this, any other thoughts, just thinking about how the current system works. And so maybe I can give a little more, dig a little deeper there. So, I'm going to go back to that slide when we talk about the current system. And
Lynn, hands up, Karen.
I'm sorry?
Lynn Perry's hands up.
Okay, well, let me go through this and then we'll grab her. So when you look at our current state and sort of what we have written in the current contract, I mean, I think an important question or an important issue to look at is sort of how does this work? And so how this works is that the peer assistance provider is responsible for screening anybody who comes in with a self-referral to make sure they're eligible. And the peer assistance provider is required to notify the person who appears for treatment of the board's reporting requirements at the time they present to the program, and looking at, if they're not eligible for the confidential treatment program. The board then, a member of the board and the board's program director meet with monthly with members of CPHP so that they can look through a de-identified list of people who are in the program so that they can make sure that they meet the criteria. And again, during this meeting, the board has no idea who these people are. They're just making sure that they're meeting the criteria. So I think that's something that maybe if people have comments on that, or they want to talk about that, or what their thoughts are about that process. I've heard a lot of, if it's not broke, don't fix it. And that's a great comment. If that's sort of what you're thinking, then I'd love to hear that. And I know the board would too, just really trying to make sure everybody has the opportunity to talk about the process as a whole and what they would like to see changed or what they would like to see stay the same. And Paula, go ahead and we can hear from Dr. Perry.
Okay, you are unmuted, Ms. Perry.
Thank you. And since no one else is speaking, I would like to bring up one additional request that the medical board look at. Confidentiality is covered not only in this issue about voluntary seeking of peer assistance, but it's also in the information you collect on both renewals and licensure applications. And one of the questions on the licensure application, which actually is not transparently available to somebody unless you're not licensed, I think, because I tried to look it up. But a couple of years ago, the FSMB, the Federation of State Medical Boards, did make a policy recommendation about questions that are about asking questions about anything that would interfere with your current practicing, and really trying to eliminate questions that people have great difficulty in knowing how to answer, like, have you ever been, have you ever been crazy, or have you ever had a problem, or if you had a problem within a certain space of time. And that's an avenue of clarity that, as long as the board is looking at these kinds of things, that would be very helpful for people to know when they're applying for licensure in Colorado, and keeping since this whole thing has been about improving transparency and clarity for licensees, I think this is also an area that should be looked at. Thank you.
Thank you, Dr. Perry. Paula, who's next?
Scott Berger.
Okay.
You're unmuted.
My hand keeps going up automatically for some reason, but I'm good. Thank you. And
that works.
Yeah, I'm of the opinion that it's not broken, so don't fix it. There you go.
Thank you. All right, Paula, I'm going to run into our question box here. Amanda Kimmel says, thank you for this. To clarify, the only people who are discussed at liaison committee are those who are deemed unsafe to practice, signed a non-practice agreement, and do not fall under the confidentiality exclusions. Thank you, Amanda Kimmel. Beth Yoder, if the process isn't broken, please don't try to fix it. Thank you. Chet Seward says, sorry for the problems with the hand raising. I keep lowering my hand and it gets raised. No further questions. And I understand that because I think you try to lower it and I try to lower it and it cancels each other out. Somehow it gets raised again, but absolutely no problem there. Comment regarding relapses. Substance use disorders, behavioral disorders are likely to have remissions and relapse. A relapse per se should not be considered non-compliance, yet under the contract between the practitioner and the peer assistance provider, and I'm sorry because the box is really tiny and my eyes are really old. Okay, so I'm just going to start over. Regarding relapses, substance use disorders, behavioral disorders are likely to have remissions and relapses. A relapse per se should not be considered non-compliance. Yet under the contract between the practitioner and the peer assistance provider, not reporting the relapse to their peer assistance provider would. Relapses are most likely to be reported by the practitioner to their peer assistance provider when confidentiality is protected and they are in a trusting relationship. Part of the peer assistance treatment program has been to determine when the practitioner must cease patient care. The board has no relationship with the practitioner and is unlikely to help the situation unless the peer assistance provider is unable to keep the practitioner from ongoing medical practice, in which case they are obligated to report to the board anyway. And that comment comes from Deb Parsons, and I appreciate that comment. Rachel Davis. This is Rachel Davis again. One other comment. I have yet to convince a pharmacy student to voluntarily self-refer to peer assistance, partially due to lack of confidentiality and partially due to perceived punitive rather than supportive assessment and monitoring process. Beth Yoder, I agree with prior speakers who have noted that it is important to keep any policies very straightforward as anytime policies attempt to micromanage. They'll invariably have many situations that do not fit the policy, creating a whole new set of problems. Christine Rivera, agree 100% with Dr. Perry and Dr. Diab. The language needed to clarify a case that qualify for confidentiality already exists in consent form for CPHP. I've been trying to research how the current discussion started. From what I've researched, the proposed company who may take over the contract from CPHP does not contain any physician or psychologist as part of their staff and specialize only in substance abuse. Treatment. This could be a barrier to providers seeking care. Peer assistance should involve care by peers at our same education level. All right, I want to make sure that to thank everybody for their comments. It's really appreciated. I want to make sure, just so that while we're on the call, we understand the board has two separate tracks here. So one subcommittee of the board will be working on the confidentiality, taking that system and memorializing it in a policy. There is another subcommittee of the board that will be making a selection on the peer assistance provider. That subcommittee of the board will be working through the procurement system, the Colorado procurement law, and I think it's called the Colorado Procurement Code, and they'll be making their selection. So appreciate your comments here, and I think it's really helpful, but making sure to understand, because I want you all to understand for transparency so that you know which to follow or both, that's how this is going to work. The subcommittee selecting the peer assistance provider met earlier this month, and that is a publicly noticed meeting, and you're certainly welcome to listen in and observe that. That is noted on the board's website, and as are the subcommittee meetings for the confidentiality, the confidential policy subcommittee. That meeting will be on February 11th. That is noted on the board's website. Those are both open to the public. They're open meetings so that you can observe and find out what's going on. And then also, if you listen into the full board meetings, which are noticed on the calendar, then you can sort of hear how the full board makes determinations on those issues. And I bring this up because I know we have a lot of stakeholders on the line that are very familiar with how the board works, and I recognize their names from years and years of interacting. But I also know that we have new people here and new licensees, and making sure that even if, you know, you can spread the word to other licensees, is you can go to the website, you can hop onto these meetings, and especially in this remote world, and just listen and get a feel so that you know what's going on. And I think that's really important, especially as we sort of move through the pandemic and move through these issues that the board's addressing. I think the more you can listen in, the more you hear what's going on, the better it is for everybody. Paula, do we have any other hands raised?
We do. James Meyer.
Okay. James Meyer, you're on mute.
Thanks. Thank you. We kind of are ending up here, and I wanted to, the last commenter before that got me thinking, and you know, and Dr. Lefkowitz was really great to be on. You know, I get the sense that, you know, what we're really trying to do is we're really trying to care for our doctors that are not well, and to try to maximize that. There's so much in the literature about impaired physicians and that sort of thing, and it's really important to give us an opportunity to, if not take care of ourselves, you know, help another physician. You know, I guess I'm a doctor, so I try to fix things, but if the medical board and if the president of the medical board is saying, you know, we really want to take care of our doctors, the last physician or prior to that noted that, you know, when we apply for our medical license or even for any kind of insurance, most of the stuff that we have to check are all negative things. What have we done wrong? How have we been thrown out? Who's kicked us off? And all that sort of stuff. I think it would be extremely helpful, or if not a very positive way, to reach out to our physicians, in that when it comes to renewing our license every year, that there's a box that we, you know, check, that we read, that just to let physicians know that there is a peer assistance program, CPHP, that has self-referral and will have confidentiality, just to let people know. And I think that's probably a really good way to get that information out there. I know CPHP has tried to get to website and try to get people informed about that, but you know, you have a 30,000 captured audience. You can get that information to them in a heartbeat, and all you have to do is just make that some kind of paragraph or some kind of thing when we apply for our license, just to let people know that if you're having problems, we have programs for you. And by the way, the board's not going to know anything about it, because this is confidential. And you know, out of 30,000 doctors, there's got to be at least 1,000 or 2 that are still suffering right now. And if they don't know about it, I would think the medical board, as Dr. Lefkowitz said, is that we really do want to care for our physicians. So I couldn't help but throw that comment out, since this is a forum that I've never really participated in before, but very grateful that I've been able to. So thank you for letting me share again.
Sure, absolutely, and I really appreciate that. Paula, who else do we have?
I'm not seeing anyone else except for Berger. But still his hand. That's up from last time. Should I check?
I got it right here. I'll check. Scott Berger, it looks like your hand is up again, and if you want to speak, you can unmute your line. Otherwise, I can just put your hand down.
I swear I have a red down arrow. No, I have nothing more. Thank you.
Okay, thank you. All right.
Don't see any.
Okay, let me just check our question comment box. Looks like Doris Gunderson has a comment. CPHP used to be mentioned in the license application. I don't know why it was removed. Lynn Perry says, many thanks to Karen McGovern and Paula Martinez for their patience, graciousness, and providing this opportunity for a robust discussion. Thank you, Dr. Perry. And let's see, looks like Rachel Davis, Dora did revise licensing questions to ask about impairment and adverse consequences rather than diagnoses. This was a huge positive step in the right direction. However, the licensing applications no longer mention the option of safe haven. Okay. And let's see. One last reiteration, and I'm sorry, that last comment was Rachel Davis. One last reiteration, Dr. Waring, I believe, made an important point to emphasize. Relapse is a common part of the healing process and should not necessarily be considered non-compliance. And that's Taj Kataparam. And again, I apologize if I'm butchering your name. Deb Parsons, the board might consider mapping out their work in both domains currently being discussed to see if there are obvious barriers or unintended consequences or other aspects to consider. Thank you, Deb Parsons. And that is all we have in the question and chat box. Does not look like we have any other hands raised. So again, I'm gonna move on to next steps, and that might, elicit a few more comments. So what are our next steps? So what we're gonna do is we're gonna take the feedback from this meeting, and again, it's unfiltered feedback because I just take the recording of this meeting and provide that to the policy subcommittee and also to the full board. We'll take the feedback from this meeting, from the meeting on Friday. We'll take all the written comments, including the policy suggestions we received from the various organizations mentioned here. Everything we have received in writing, everything that has been said in these meetings, and anyone who returns the survey, all of that will be provided to the board and to the policy subcommittee. The policy subcommittee will meet on February the 11th, and they will, discuss and start putting pen to paper. And so I encourage all of you that are interested to phone in for that meeting. Again, you can find the login information on the board's website. And once I finish with the slides, I'll take you to the website. So for those of you who aren't familiar, you can see the link. Once the policy subcommittee makes a determination, they'll make that recommendation to the full board on February 18th, which is the Colorado Medical Board full board meeting. And that's the regular quarterly meeting. Again, that'll be on the calendar and I'll show that to you. Once the board agrees on a proposed policy, then we will take that draft policy and we will re-engage you. What that means is we will set more meetings like this. We will send you a copy of the policy so you can look at it and you can provide feedback on the actual language. So you can say, I like this, or I don't like this, or remove this. And that sometimes is a little bit more concrete for people to provide comments and feedback. I do feel like today people were very engaged and really didn't have a tough time addressing some of these issues, even though they haven't seen the proposed policy. So before I show you guys the website, so are there any questions? Does anybody have any questions that we can answer? And you can show that by the raise of hands, and I'll ask Paula to take a scroll down the list.
I'm not seeing any hands.
Okay, so I'm just going to turn off my screen share here for a minute so I can get to the website and show you what that looks like for those of you who aren't familiar. Just give me a couple of seconds here. So here we are. You can see that we're on the Colorado Medical Board web page. And the web address is dpo.colorado.gov/medical. And if you don't remember that, then the easiest thing to do is to go into Google and type either Colorado Medical Board or DORA Medical, and you'll get prompted right to the page. Once you get to the page, you can look here under public notices, and that'll talk about the stakeholder meetings and give you ways to download draft rules or draft policies or webinars. And then you can see here, this is where the early stakeholder engagement that we just did, where that's listed. And it has Paula's email address here in case you want to send her comments. And then if you look over here, you see it's called Medical Public. It's the calendar. So you can see here, the next one is the Policy Subcommittee meeting at 10 a.m. on Thursday, February the 11th. And if you click on it and you click on more details, then you will get an agenda that will pop up. And you can see, here's the agenda for the meeting. Here's the link to register for the webinar so that you can listen in. And the agenda talks about what will be covered. So for any meeting that you're interested in, you can just click on those links and you can see if it's something that you're interested in. So if you look down here on February 18th, you'll see it's the quarterly meeting, right? The one on the 18th. Just do follow the same thing, click more details, and you can get the registration to register for that. I bring that up just because I want to make sure that for any new people on the line, you know how to engage, you know how to watch the board work. I want to thank you all for spending the afternoon with us and for all of your thoughtful comments. It's really helpful for the board to know sort of where you're coming from before they kind of embark on this big task. So thank you so much. I appreciate it. And thank you again. I'm hoping everyone has a really good afternoon. Bye-bye.